Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by
All
anybody.
right. So let's start with the paper 4 of October 24. And let's first jump on to the first question. Like I was giving a brief um, introduction about the recent advances folder, which has a very important role to play in answering for paper number 4. And I tell my students who are, not able to have enough time towards the end, that if you do the recent advances of the latest volumes of everything, like AOGD journals 2024, 23 at the max, and maybe now for 25, whatever comes in 25, then about TOG articles, whatever the latest TOG articles of 24, 25 are, you can do that. And the latest volume of Johnstad and recent advances, if you do, that should be sufficient to at least prepare you for for the paper number 4. And I think every day when you're doing your theory course, take out 1 hour, necessarily to give to recent advances, okay? And everybody who takes my theory course gets the recent advances folder, but the ones who are going for my answer bank alone, they should purchase this recent advances folder separately, because now the recent advances folder is a highly coveted, enriched folder. A lot of stuff has been added, which is practically very important for your paper number 4. All right, now let's start with the questions. So discuss gestosis score. This is a repeated question. Basically, there are certain scoring system in low resource settings, like in India. If you can just ask a history properly, extremes of age, maternal anemia, obese patient, she's primary, or cohabitating with the patient since a shorter span of time, family history of cardiovascular disease, PCOS, all these are lesser factors for making her into a hypertensive patient. But excessive weight gain during pregnancy or hypothyroidism in patient, a family history of preeclampsia, gestational diabetes, obese of the higher order, multifetal pregnancy, previous pregnancy with hypertensive disorder, and even more, like type 1, type 2 diabetes, or chronic hypertension, or mental disorders, or thrombophilias, or chronic kidney diseases, pregnancy with assisted reproduction, and history of hypertensive disorders of pregnancy, correct? So from here we see that a score of 1 usually means low risk, a score of 2 indicates moderate risk, and a score of 3 means usually a higher risk. So you should intervene when a patient is having a score of 3 or higher. She is considered at risk for preeclampsia, and treated accordingly means that you have to ask her for frequent visits, earlier check on the blood pressures, start her on aspirin, that is now with the aspirin trial. And certain people, they put her on calcium, vitamin D, magnesium, this thing, yeah. So these are newer advances. We don't have very robust evidence for these, but there are all schools of thought. So we usually start them on high dose of vitamin D, also on magnesium. We've seen that it gives good results. Apart from that, of course, aspirin is definitely recommended, and earlier catching of the slipping of the patient going towards the hypertensive disorders of pregnancy. That means frequent visits, right? Then there was a question on management options of cesarean scar pregnancy. Now remember, guys, I think when I was teaching you ectopic pregnancy, I told you that there is a cesarean scar pregnancy can develop outside or it can develop inside. There is, in many books, it's given suction evacuation for an cesarean scar pregnancy, but it'll bleed. It'll bleed torrentially. It'll not, first of all, it'll bleed. Secondly, you'll not know whether you've been able to take it out completely. Third, you'll not be able to know whether you have, in the process of suctioning it out, made a dent in the previous cesarean scar on which it was attached, correct? So always and always, the best modality of management is the medical, that is systemic and local methotrexate if possible, otherwise surgical management. It's the same thing which I've said over here. These are nice guidelines. So yes, medical management is very good. Okay, you can only for a hemodynamically stable patient, you can go for this. Otherwise, surgical removal is the method of choice. You can go for a laparoscopic approach over here, or you can go for a laparotomy. Both of them are good enough, but you have to go for surgical management. But yes, if you have a very lower level of beta HCG, the scar is also ectopic is very small, and you feel that this is not going to grow and it's not growing further. By 2-3 scans you did, or the 2-3 beta HCG you saw that it's not growing, in fact it's coming down, then you can go for expected management. But usually you should go for the best choice is to go for the systemic and local methotrexate. The second choice is surgical management. Now, if you have any doubt, guys, please let me know in my inbox. Okay, we have for everybody, I have this chat room available. So anybody is having any issues, anybody with any issues, please make sure that you're letting me know in the chat box, and we can discuss it and we can take it up from there. And I would also want to know, for all those students who are there in the class, how many of you are undergoing the upcoming practicals, and how many of you have the theory exams coming up, and they are whether you know the dates or tentative dates, so that my further classes can be scheduled as per your needs, not as per what I want to teach you, right? Okay, then there was a question on screening of hemoglobinopathies in pregnancy. Now, this question is very ambiguous. Let me tell you, when I was making it also, I did not understand exactly how to make it. And I don't think this question has come before. So indications of screening. So first of all, when will you screen for hemoglobinopathies? It's not a universal screening, number one. So universal screening is only recommended in populations where there is high prevalence of certain hemoglobinopathies. Okay, so like in Mediterranean region, you've got thalassemia is very popular. Okay, so then in South African countries or African countries, you've got sickle cell disease very, very popular. So there maybe it can be a universal screening. But in India, as such, there are certain places which are known for, sickle cell disorders or thalassemias. So in that case, you can go for universal screening. But otherwise, you do targeted screening based on ethnicity, family history, or abnormal blood indices. So you go for CBC and you feel that no, despite of everything, her hemoglobin is not increasing, then go for HPLC, all right? So screening test, what all do you have? You have full blood count, you have electrophoresis, which I was talking to you about, that is high performance liquid chromatography, HPLC, and then maybe later on DNA testing. What should be the timing of the screening? If you want to do a screening, it has to be at the booking visit, because that will give you a timely, time to allow for a partner testing as well, genetic counseling as well, genetic testing as well, correct? So once you've got the patient known, okay, fine, she's having sickle cell disorder or she's having thalassemia, you get a father to be tested. So once you have that the couples are at risk of having an affected fetus, definitely give them an option. Give them an option of CVS or give them an option of amniocentesis, correct? And you should accordingly manage the high-risk pregnancy with multidisciplinary team.